Welcome everybody, welcome to the Children's E-Hospital webinar on PANS PANDAS, where we're sharing experience with Amy Smith from the US. So today's seminar, which is also going to go out as a podcast, is going to be looking at the way that PANS PANDAS is managed in the US, how some of those management strategies and perhaps even diagnostic strategies are different to what we do in the UK. And actually to have an opportunity to chat with Amy about her experiences as an individual, as a parent, and also as a health professional. And I know that I mentioned to somebody that we were going to be talking to Amy Smith, and they described her as the queen of PANS PANDAS. So that's quite a title to live up to, Amy.
Uh-oh.
So Amy, I'm going
to
I'm going to ask you just to say hello, but before we get to that point, what I'm going to emphasize is that we're going to be having lots of questions and answers, because I know that that's what you as parents really want. So you're going to have a lot of opportunity to ask Amy questions and hopefully have some discussions that might help us all actually in this big family of ours. So when it comes to questions, there are a number of ways of doing it. There is a Q&A box that you'll see on your webinar screen that you can ask questions through. And actually, when we get to the actual session, you can raise your hands if there's a specific question that you want to ask. Anyway, so with nothing further from me, Amy, welcome.
Thank you.
So Amy, tell me about what it was about you and your life that pulled you into PANS PANDAS.
Well, my son developed his, I think the way I speak about it is his big pandas break, because there do tend to be those smaller self-righting blips of change when kids are younger. Mm-hmm. And exposed to triggers of PANS, and then they're pretty much self-righting. The inflammation is able to resolve. And then very, very often there's that big one from which they don't recover on their own, or at least for a really long time. So for me, that was July 7th, 2006. And it took about 3.5 years to figure out what my son had. So he was just barely 10 when it started. He was just about to turn 14 by the time I figured out what was going on. And then it took till he was 17 really to get him well. It took a long time just to figure it out and work on that. So at that point, I've been an integrative medical provider for a long time. And I was doing a lot of food as medicine primarily. Mm-hmm. And that took me in a kind of a medical detective model based on chemistry, people's chemistry and influences on their health and their lifestyle and so on. Yeah. So I was kind of made for that type of curiosity-driven, inquiring path of trying to sort it out, even though food as medicine did not work in this situation.
So can I ask you about that then specifically? So a couple of really interesting things that you've already mentioned. You said the date, the exact date that things changed, and that a lot of parents come through with that. You know, it's that thing that Sue Swado talks about, where that switch is thrown and you get a sudden change in your child.
Yeah.
What was it about your child that made you think that first of all that there was something wrong, and then secondly, presumably you went down the standard medical route initially to try and seek help? And,
oh, of course.
And what happened on that route?
So his first thing that happened that morning, it was about 10:15. I just will never forget the moment. And he just kept saying, "Oh, my ankle is bugging me. I mean, my ankle is bugging me." And I'm like, okay, because he had some moments of being a pretty intense kid. You know, he was probably sensitive. He'd had some sensory stuff kind of come and go, which now I know was early PANS and PANDAS related stuff. Sometimes it was there, sometimes it wasn't there. So some things that he said, I mean, I just had to let it roll off. I mean, he was just that kid. But I couldn't figure out what he meant by that. It was moving, it was twitching. He'd been hit by a pitch because he was playing baseball and he was a pitcher. And, you know, I just thought maybe it was that. But his anxiety about it and this relentless, it just gripped him. And then that was that morning. By the nighttime, it wasn't just his ankle. It was his leg and his pelvic muscles. He had to keep squeezing his butt, and, you know, just, he couldn't stop. And at that period of time, we were actually in the middle of moving from the East Coast. We were living in Atlanta to the West Coast. So he and I were doing this road trip. The next day, I thought, okay, well, you know, bringing our bikes, we're going to go across the country and I'm going to show him the Grand Canyon, stuff like that. We were so excited. But by the time we got maybe halfway across the country, it wasn't just the movements and the muscle thing and his anxiety, but then his OCD. He started counting everything. And he ended up, by the time we got to Salt Lake City, I just remember he was laying in the back seat with a shirt over his head, because every street light or post and the white lines on the highway had to count them. He was going nuts. He had this just dark shadow over him that I so associate with pandas. And I just remember driving like a maniac across the country just to get wherever it was that we were going. And the very first thing we did was go to the Kaiser emergency room. So that was where our insurance was through. It's a HMO, very medical, straight medical. I drove him right to the emergency room. I just thought, something is wrong here. And I had no idea what it was. But the first thing they did was, when the doctor came out, he started talking to me about my autistic son. I said, he was not like this like a week ago, week and a half ago. He was not like this. And they, either they didn't believe me or they thought I was an idiot. I mean, I'm a pretty professional, believable, straight-laced person. And so if a mom says he wasn't like this a week ago, you would think they would say, wow, that's messed up. Like, maybe he was poisoned. Maybe he has meningitis. Maybe he has, you know, a brain aneurysm. I mean, I just thought there was something going on in his brain. They could not have cared less. They just said, this is anxiety. They gave me some Ativan, which I gave him, and he, you know, started. It was not a good match. So, but that's how it started.
So that experience. So you're a health professional. You've got a child that has changed quite dramatically. You go to an emergency room, and somebody says, well, somebody basically disregards that there's an issue here.
I know. I'm like, what about a lumbar puncture or a CAT scan or something's going on here? So, no.
Okay, so at a very personal level, because I'm sure that this will resonate with lots of parents who are on this webinar. On a personal level, how did that make you feel?
Well, extremely powerless. Really scared, frustrated. I mean, it was just really scary because he was suffering horribly, and I didn't know what to do. Plus, we had just moved. I mean, that was our first stopping place moving. So now we were living somewhere I didn't know anybody.
Yeah.
And people just got to know me as this, like, you know, stressed out mom of a sick kid. Like, that was my entry into this whole new environment, which unfortunately was a lovely small town in Sonoma County, Sebastopol, lovely people. Yeah. But it was consuming, completely consuming to me and to him and to my husband. And every minute of every day was trying to figure it out. And I did what they recommended. We went to therapy, did cognitive behavioral therapy. We went to the psychiatrist. I tried 10X. We tried Zoloft. Nothing helped him. They made him worse, if anything. I tried all kinds of foods. We did Ayurvedic stuff, acupuncture, other forms of therapy. We did biofeedback, somatic therapy, trauma therapy, just nothing. I think I had a shaman come to our house at some point. I did. I thought, I don't know what this is.
So that's a spiritual person to try and cast out evil spirits, yeah?
Yeah.
Yeah, wow.
Totally. He's sensitive, you know?
But I guess that demonstrates just how lost you were, because you had nowhere else to turn.
I had nowhere. And he was up most of the night, and then the rest of the night I was up, you know, online, just looking and looking and looking. And we went through all of Kaiser. We did developmental peds, all the pediatric people, the psychiatry people, the outside people. By the time I actually figured it out, so that was, you know, July of 2006. By the time I figured it out, it was early December of 2009. And by then, we'd been to upwards of 30 people. I was separated from my husband. I wasn't able to really work because I couldn't fully establish a practice there. He was in school, out of school. It was terrible.
So that's 3 years.
3 years.
Well, and so
almost 3.5.
When did you first come across PANS PANDAS as a possible diagnosis, and then how did you pursue that path?
Well, I was looking, you know, obviously I was online all the time, and I saw something that said pandas with tics, because that was the main driving thing. The OCD too, but the tics were just relentlessly torturing him. And I saw one thing online that said blah blah pandas, strep, tics, and I didn't put it together, but he'd had strep in March, so this was July. He'd had strep in March, and he also had strep at least once the year before, maybe twice. It might have been once a year for 3 years, or it was that year and then twice the year before. Okay. He took Keflex, you know, because he's allergic to amoxicillin.
Some people might not know what that is in the UK. So that's an antibiotic that he took, yeah?
Yes, is an antibiotic that's routinely given for strep. The one before his last one, he did have a little bit of a rash, you know, and fever. He was really sick, but he just seemed to completely recover. I didn't connect that to anything, but knowing what I now know, looking back, there were a lot of things but it's always in hindsight. I mean, I never made connections like that. But our last year that we were living in Atlanta, I went through a thing where I had a sore throat for months, and I kept going in and getting tested. I got tested for strep. I got tested for viruses. Nothing ever came out of it. And then he had this low grade thing, and with a sore throat. But it just was in the mornings or whatever, and he tested negative for strep. But it went on for months, and it may have been in his tonsils or mine, or so we had that definitely happen. And then a completely random thing that I hate to think about, but when he was maybe 7 or 8, it was I think in one of his early PANDAS things, he had a lot of sensory stuff. He was having trouble sleeping. He was agitated. I mean, he just wasn't quite himself. And being who I was, I took him to a homeopath. And because he had his normal checkups. I mean, his normal checkups were always fine. And so I took him to a homeopath, a very well-known guy in Atlanta. And for just a remedy, a constitutional remedy. And then he did this thing that I didn't really understand, and I was highly dismissive of it at the time. He did a salivary thing, and he put it in some energetic machine of some kind. And he said, oh, he's got, a sensitivity to red dye, might have a little thing to wheat. And he said, he has group A strep in his throat, and you should do something about that. He was not sick. He was about 7 or 8. If only I would have fully, really freaking jumped on that, because he had a negative, I took him to his doctor. He had a negative throat culture. I didn't have those things at my house. I had to take him in.
Yeah.
And so he gave me these drops to give him for strep. And but they were supposed to be 3 times a day. Who can do 3 times a day? I did it twice a day. I thought, okay, that's enough, because it just seemed too far-fetched.
Yeah. And actually, I guess that was way before the time where you started significant symptoms. So, yeah. Wow. I mean, so. I think what we'll probably come back to the rest of your personal story later, but what I want to do now is perhaps go forward, sort of fast forward a little bit into how you started to see PANS PANDAS patients, and really what your journey has been through that, what treatments you used, what you found has worked, what any bits of advice really that you can give me or us as a population in terms of how to approach this this condition, which can sometimes just tear families apart.
It definitely tore our family apart, and it can happen, of course. Well, there's a lot in that question, so I'm just going to take it piece by piece. Okay, so your question was, how did I start seeing other families? So by the time I figured out that it was PANDAS, it was the winter of 2009. And at that point, for those couple months, September, October, November, December, that fall, I was able to join a practice. I'd been invited to join, but only 2 days a week, because my son was doing a little better. The summers were always better. So I was able to work 2 days a week, and that was how I ended up figuring it out, because I could order my own testing. That was kind of how that worked. And I had a colleague, a wonderful integrative physician, that brainstormed with me, and we thought about all the things that it might be. And I mentioned that one thing I had seen back early on about PANDAS that I had spoken to another provider about. He said, oh, that's so rare, we never even test for it. And I'm like, okay, like that was almost a year before. So we tested him, and his DNase was like 1800.
Whoa, that's high.
To this day, I've never seen another one like that. His ASO was over 1200.
Yeah.
So that was actually fascinating. So that was December of 2009, and started him on antibiotics shortly thereafter, which I was really afraid of. He was on and off and on and off, but it really helped. And in April, so I was looking at that point at some literature, just seeking out information about PANDAS. That April of 2010, I got a call from a nutrition client of mine who said to me on this voicemail, she said, I'm so sorry I haven't gotten back to you. My son was recently diagnosed with this incredibly rare illness called PANDAS. And we just were in Chicago getting this blood treatment. And I never even heard her entire voicemail. I just called her at work. And she had a little boy who was 8 years old, and he had been diagnosed with PANDAS, and they had just come back from getting IVIG with Dr. Kovacevic in Chicago. And he was one of the very early PANDAS providers. So that was how I began to connect to other people. She already was connected to some other moms and to Diana Pullman, who at that time, it was pre-PANDAS network, but was in the formulation of connecting people, connecting up providers with the National Institute of Mental Health. And like she was in the early stages of pulling people together to create a broader dialogue. Well, they drove up to my office the following week, and we talked, and I just felt that point, I'm treating it. I'm made to treat this illness. I have the background, in peds and just integrative medicine. I have a big toolkit, the interest, the personal knowledge, and I'm meant to do this. So they started sending people to me.
And what in the very early days, what sorts of treatments were you using, and how does that differ to where you are now?
Interestingly, not a ton in a certain way, but I became very clear early on that you needed antibiotics. I tried it without antibiotics. I was not really into antibiotics. I mean, I was doing Buddhist medicine. I have a really broad antimicrobial toolkit, and I rarely prescribed antibiotics, even though I certainly could as a nurse practitioner. But it was the antibiotics that were the game changer, number one. So I was very clear about that. And I was also very clear about the inflammatory component at that point. So I tried a lot of different anti-inflammatories that were out there. And the very first thing I went to, of course, was curcumin, because there's a lot of literature about, it broad anti-inflammatory properties, including in the nervous system and the brain. And I didn't find it help. Not like ibuprofen, but there's only so long you can give ibuprofen, before it starts causing problems.
What's the sign of interest? What's the longest that you've had somebody on ibuprofen for?
Oh, I'm sure I've had kids on ibuprofen for upwards of a year. Not that I want to, but in certain circumstances, and then you try to get off and do other things. But it depends on what the other things are and how those other things are being established, right?
Yeah.
So
I'm just going to make a comment at this stage, because I know that there's lots of parents that I'm treating on this call. So you're not allowed to do this, by the way, parents, okay? Not without medical supervision.
Right. Right. If you give ibuprofen, it can cause.
It's about monitoring toxicity, isn't it? It's about making sure that when you're giving treatment, that it's safe. Yeah.
100%. And trying to, if you do need to use something that has some potentially impactful and even damaging side effect, to do everything that you can to work around it and ameliorate that, or obliterate the likelihood of that side effect. For example, with antibiotics, they can cause a lot of downstream problems in the microbiome and certainly in the gut, but really in the microbiome, right? In the intestine, and the very delicate balance that is supposed to have of healthy fermenting bacteria that keep us healthy on an immune level, that keep us healthy on an inflammatory level, and that gut-brain connection is a very, very real thing. Yeah. So in order to protect people against the effects of antibiotics, how important it is to use a lot of probiotics.
Okay. So that,
right, and other kinds of gut support. So those are the things that you can build in.
so I know lots of parents will be very interested in a bit, because this is a part of the sort of the functional approach that I'm not very good at. So if you were to, and it does make sense to think about protecting the gut if you're going to be on antibiotics for a long time. We need
Even a short time.
even a short time.
Even a short time.
So when you say a short time, do you mean, so if you have a child on antibiotics for 2 weeks, would you give them probiotics as well? You just start
Yeah.
them and so
start it on day one and continue it for at least 2 or 3 or 4 weeks after.
Oh, that's interesting. And what type of probiotics do you use, and what's the impact of using them?
Well, you know, it is a little different for different people, but I'll tell you some of the common ones that I use with antibiotics. One is a strain called Saccharomyces boulardii,
Okay.
Sac B. You can get it by itself. There are also some blends that have the Sac B in it. Sac B, what's nice about it is that it's a non-pathogenic yeast strain. It's not bacteria, so that it does not get killed off by the antibiotics. However, it's lactofermenting. And so it maintains the pH and certain fermentation functions. It produces short-chain fatty acids that keep that inflammation along the walls to a minimum and continue to support just good immune power there. Mm-hmm. It also competes with Candida type of yeast. That is one of the biggest side effects of using antibiotics, is this yeast overgrowth, mm-hmm. right? And so the Sac B is a placeholder for the other bacteria, and it keeps the environment sound so that things don't go fully down the tubes when you're on antibiotics. If you're on a short-term antibiotic, like really for 2 weeks, you can probably use the Sac B by itself for a couple of weeks, and then when you're done with the antibiotics, then I would introduce a broader kind of probiotic that has lactobacillus and bifidobacter strains in there, just to help and repopulate the gut so that things get us back to normal as quickly as possible. And that's probably the minimum that I would do. Sometimes I use prebiotics. It depends on that child, you know, their symptoms, any prior GI history.
Okay, so we have got a couple of functional medicine doctors on the webinar. So if you're willing to just come up to the panel level, just raise your hands and we'll bring you in. And there are some people coming through some questions. So okay, so there's an anonymous question here that says, what are your thoughts on antibiotics / steroids as a longer term treatment?
As a long-term treatment? It wouldn't be my first choice for long-term treatment, especially the steroids. Long-term steroids can have profound effects on immune function, on tissue growth and turnover, bones. You'd have bone loss. There are so many metabolic changes that can happen for the negative on long-term steroid use. It's really for short term. Yeah. So if somebody really, in my world, all right, so if I had somebody come into my office saying, you know, we're okay as long as we're on antibiotics and steroids, if that was what they said, I would apply my general algorithm to how I approach each person. Number one, I'd be sure we've identified and treated or removed whatever their infectious or immune triggers are. Right? I mean, that's got to be number one when you're talking about PANS and PANDAS, right? Number two, of course, reducing inflammation. And number three, what other immune modulatory therapies are possible for this person?
Yeah.
Right? Like someone like that, if you really have identified and treated or removed their infectious triggers, if it was really primarily strep or there was a virus or whatever, and they were under control with that, they really might need IVIG. I mean, that would be a great potential solution for that person.
Yeah, so,
and lasting, and then you get them off the meds, like a cure, you know, a potential cure.
So you'll know that in the UK, we've got a real problem in accessing IVIG. So what's happened over the last 2 years in particular is that we've had to adapt to learn to use other techniques because of the just the lack of facility of this simple treatment. And steroids has been one of the pillars that we've used to lead against for this problem. But you're absolutely right. Steroids don't come without side effects. I mean, I would say that no drug comes without side effects. Whatever you give people, you've always got to be careful about them. But in terms of IVIG, there is a question that's come through, which was one of the first questions, which Ben Chandler.
What do I think about it?
Well, Ben simply put, and it's good to hear from you, Ben, by the way. He's put, I would love to hear your thoughts on IVIG. So I know you're an advocate, but tell us what your experience has been with it and why you think it's so good.
I just see it work a lot of the time. Mm-hmm. That's why. I mean, it's when I think of the things that work for my kids, you know, in addition to identify and treat or remove infectious or immune trigger, and get the inflammation down, IVIG gets people off the roller coaster a lot of times. And it just works. I don't use it all the time, you know. I've used it primarily when it's really strep triggered, not as much PANS. And it's really, really PANDAS because I feel that it's a match of the known pathways. But what is so interesting is this recent information that has come out from Columbia about, and that's in their video that I sent you, about basal ganglia encephalitis, which is really what PANDAS is, and they're just trying to use, you know, a more medically accurate term for that, so that's why they call that in the study. But Dratan, who is the primary author of the paper, said that in the literature, he has seen not only bacterial infections trigger basal ganglia encephalitis, but also viruses and fungal infections and triggers. So that is something I've been really thinking about a lot these last few days, and it makes me wonder if IVIG would be effective for more than just the PANDAS specific population. I mean, if it's really that basal ganglia encephalitis and it is related to a number of immune triggers, it makes me think, why am I limiting it, you know, to just those kids? And we can't always get it either.
Yeah.
You know, like in the United States, this is a massive country.
Yeah.
And there's no organizing principle here. It's random. People are shooting from the hip. They're doing this. They hate that. They hate them. They do this. They want that. There's no cohesive treatment pathway or protocol in the United States for PANDAS or PANS.
I mean, we're in a very similar position, actually. I mean, we started we developed a protocol that was published nearly 2 years ago now. Well, I don't know if you're aware, but we have got some issues in the UK at the moment with particular individuals who are potentially being threatened by the regulatory authorities, by the hospitals that they work for, and you know, their jobs are on the line as a result of them treating kids with PANS PANDAS. Is that something that you've seen in the US?
Yeah, it can be very dangerous for people, for sure, because it's not fully condoned. It is more and more condoned. You know, there's more and more literature coming out all the time. So, and PANDAS and PANS are supported by major academic medical institutions here in the United States, but it hasn't trickled down through the American Medical Association. It hasn't trickled down through the American Academy of Pediatrics. So that unless those professional societies really subscribe to it, it's still.
The question was, do you believe in the US PPN protocol?
To a certain degree, you know, I mean, everyone is a little different, but the PANDAS Physicians Network protocol, you know, says to initiate antibiotics. They have like kind of I haven't looked at it over the last few months in case it's changed, but you know, I'm quite certain it said in the beginning to keep them on it for at least a month or longer if they're continuing to improve, and even as much as a year, right? And I tend to keep kids on antibiotics to some degree until when we withdraw them, they do not decline.
Okay.
Because that brain, you know, protecting their brain, I believe, is the most important thing. I can always protect someone's gut from an antibiotic. There's a lot you can do.
Have you ever had problems with Clostridium difficile when you give long-term antibiotics?
I have had in the like almost 800 kids now that I've been treating, I've had 2 cases of C. diff.
Yeah.
2. And both of them was really easy to deal with. And one of them, I took him into my practice from another provider with active C. diff, who'd been on a lot of antibiotics without a lot of gut support. And then this other little girl, you know, we got her out of it, and we're even, and of course I took her off antibiotics for, you know, quite a period of time until we could safely reintroduce them. But I've never had somebody, and that's it. That's my entire experience with C. diff. 2.
That's interesting. So that means your risk is 0.25%, a 1/4%, you know, of C. diff in your population. So and in my population, it's 0.3%. So we're not far away from each other. So
that's nice and low.
It's so low. Yeah, it's really interesting to hear that actually. So. And that does actually, because that's one of the arguments that's being bandied around in terms of use of antibiotics for longer periods of term, is that it, you know, risks a C. diff. But with all of your patients, you're putting them onto probiotics at the start, and they all get that.
I absolutely do. I do probiotics, sometimes prebiotics, sometimes fibers, you know, whatever it takes. Like I have some kids that are on 3 different probiotics, you know, for whatever that is for that person. But you know, even the risk, when I think of the risk involved between dealing with antibiotics, even in the worst case scenario of C. diff, compared to not treating someone's brain and the downstream and lifetime costs of that,
yeah,
it is the obvious choice.
Yeah. Okay.
Right.
Okay, I'm going to move on. Elsbeth Vine has got a question. She says, what about those children who have no strep antibodies in the blood, 0 titers to strep and all other bacteria commonly tested in PANS, including not developed titers against bacteria and vaccines? Are they seen as immune? Doesn't sound like they
What
are.
about the vaccines? First of all, I missed just that very last. So they did
So,
not develop titers to vaccines?
no, it's from her question. She says they do not develop titers against
Oh,
bacteria in vaccines.
okay. So there's a whole bunch of embedded questions in here. Okay, number one, no strep titers means nothing. Means nothing. Positive strep titers can be very useful. But, you know, to me, when it comes to strep titers, a positive is likely a positive and a negative is a maybe. Because the ASO and DNase antibodies against strep, Dr. Pat Cleary, who has been a part of the academic consortium, like one of the early researchers that Sue brought together, that Dr. Sue Sweeto brought together. He's from the University of Minnesota, infectious disease guy, loves strep, has published about strep for decades and decades. And he told me early on that the proteins that those antibodies are against, the ASO and DNase proteins, that those are from strep from the 60s and 70s and maybe 80s. You know, life evolves. We don't use last year's flu vaccine, of course, you know, take the whole COVID thing out, but, you know, we're aware that things are always changing. The strains, bacterial strains, some are rheumatic, some are not rheumatic. And we can't use those tests anymore. They're just not valid. And they haven't updated the testing. In fact, I was just talking to Children's Hospital of Orange County rheumatologist, Dr. Whelan, who sees pandas kids there. And we were having this very exact conversation. You can't rely on those titers to know whether someone has been exposed to strep. And what we used to say is that they're a non-responder to strep antibodies, but I think it really varies based on the strain that they're exposed to, and there's plenty of literature to that effect. So there's that piece. Number two, however much testing we do when we try to identify and treat or remove the infectious or immune triggers, the things that we can actually test for are like a pinhead on our pinky compared to the number of things that people can be exposed to in any given window of time. So sure, if it's mycoplasma, isn't that wonderful? If it's strep, it's so great. If it's Epstein-Barr, sinus infection, how many people have sinus cultures? Hardly any. So I'm always suspicious that there's something either that we're not testing for, if they haven't had a culture there, or that, you know, we don't have a magic, like a Star Trek scanner that can tell us what bacteria or viruses or whatever are present. We have to know how to ask for them. Then we have to be able to test for them, and insurance has to be willing to pay for them in order to test. So it's a teeny, infinitesimally small amount of stuff we're able to test for. You can't go by the testing. That's why it's a clinical diagnosis. That's the whole point. And just the thing about the, you know, if that person at the same time does not mount an antibody response to vaccines, it's also possible that the testing that they've had, they might have false negatives. If they're, you know, have an immune deficiency, and even if they do have, for example, Epstein-Barr, they might not have the antibody response that the lab is going to pick up in order to say, oh, hey, guess what? You have Epstein-Barr. So it's harder.
Yeah, and I think Elspeth does actually kind of come back to that later on in a later comment. So I think she is asking specifically about whether this might be an immune deficiency. So
sounds like an immune deficiency.
yeah, absolutely. So it is important to search for that at the start of the process of treatment. Okay, that's great. Thank you. So okay, now here's an interesting question from my son has a very high B12 result in his blood tests. I imagine it isn't getting into his cells. Any advice? He is 7 and PANDAS diagnosed.
I would consider the possibility that that's probably accurate. And I mean, I don't know your son. I mean, these are all just general answers, yeah. Okay? I mean, everybody is so unique.
You can imagine what everyone's going to do at the end of this call, can't you? Everyone's going to go out and act on it now. But
I know. But it is possible that a child who's not taking B12 but has elevated B12, they may need a different form, like they may need methyl B12 or hydroxy B12. It really is possible that they're not activating it. And for me, one of the better tests for B12 is a methylmalonic acid. You can do urinary methylmalonic. You can get a blood, maybe if you're lucky. Methylmalonic acid is looks more at the methylation complexes of B12. So that could help. Homocysteine could also maybe help.
Yeah, so there's a B12 pathways that can be quite important. Interesting, Mary, I also came across this issue a few years ago, and I remember when we went to the meeting in New York, I remember raising it with all those amazing world experts that we had at our fingertips at the time. And we had a discussion about this, about why is it that some of these patients have this incredibly high B12. And I think it was Tanya Murphy who said that she'd looked into this, and her thoughts were that this was an inflammatory response because she'd seen it again and again. And it's similar with lots of patients that I've treated and where I've actually measured it, it seems that it's a phenomena, but it's a post-inflammatory phenomena. And it seems to come down as the inflammation comes down. Now, that could be linked with the metabolic pathways that are involved as well. So, you know, they could be very...
Exactly.
Yeah. Okay, great. Thank you for that one. So that's good. Now then, Ali has asked, are you aware of PANS caused by Candida?
Well, I would have to say yes, because the definition of PANS includes the effects of somebody that might have Candida or a yeast infection. I do see plenty of kids with or without PANDAS with yeast infections, have some brain fog or disinhibition, a little hyper, craving sugary foods, and by definition, you know, anything that changes a child's behavior on a chemical level qualifies as PANS. So I guess for that reason, it's just this mother category that's just so ridiculously big. But yes, absolutely. And treating the yeast can really help many kids to settle down and think more clearly. I have a large group of patients with autism. Those kids with yeast do tend to be more stimmy, in my experience.
Okay, I think this next question is one for me. I think it is anyway. So, if money were no object, would you take your child to the US? We've been trying for 7 years to sort our child out and his life is slipping away. So that's a really difficult question because I've got two hats here. I've got my parents' hat and then I've got my physician's hat. As a physician, I would say that you should be able to access, and don't all throw things at the screen when I say this, that you should be able to access the right care, whatever, in this country. I know the reality is very different and that a lot of you are struggling to actually access care full stop. I think as a group of physicians, particularly with the PANDAS network, we've evolved and grown incredibly. And we've got great treatment pathways, which I think work very well as long as you're willing to be patient. Now, there is a group where I think IVIG would be just fabulous and would provide a quick resolution of the symptoms, which may be sustained. And I think in that situation, then if I was a parent, and this is my parent hat now, if I was a parent and I had a child who was suffering and I had money to take them to the US, yeah, of course I'd take them. Yeah, it's a no-brainer. Yeah. Okay. So is that one done? I think we identified pandas very quickly in my daughter, who was ill, and then quickly tortured by OCD ticks and contamination in December. That was in December 2019. The online community helped me and I got antibiotics. She's had a total of 8 or 9 weeks of antibiotics now, finished, so no medication at the moment. She's largely symptom-free or very reduced, but each time she flares in future, do we ask for antibiotic use, ibuprofen, or is this just a sticking plaster? I'm going to let you answer this first. And I'll tell you what, why don't you answer it, and then I'll do my UK answer as well. Yeah?
So, you know, the main thing is that you always want to protect your child's brain. Like, that is the defining feature of what needs to be done. So, if she flares in the future, you definitely want to use anti-inflammatories, right, to get that down, whether it's, I see a little air in my closet, you know, ibuprofen, as long as, or Aleve, you know, here, naproxen, either way, as long as she's able to handle it and her stomach handles it with food. Sometimes there's other supports you can use. So I use herbals as well in my practice, so trying to amplify the effects of ibuprofen, but in an acute situation, ibuprofen is a good thing. And I would consider the possibility of using an antibiotic in the future if the flare doesn't, you know, resolve in a very short period of time with ibuprofen alone, because it's that inflammatory thing, and the longer it goes on unchecked, the bigger it can get. And when it gets really big, it's harder to get that fire out. So you want to try and get the fire out, and don't give it that long before you put the big guns at it.
Yeah. Okay, great. So
is that what you would say?
So I've got a slightly different slant on it. I've got much more of a UK slant, and that's because one of the things I'm really, as all my patients will tell you, is I try and minimize their treatment periods as much as possible. So and that's because I worry about long-term implications in my population. And actually the political backdrop we have in the UK in terms of antibiotic governance and, you know, minimizing drug usage. So what I advise is right at the start of treatment is to do I give 2 weeks of antibiotics, and then I give 4 weeks of prophylaxis. And the rationale behind that is to allow the antibodies to just decay down. So normal antibody kinetics. And then you get to a baseline. And then if you're in Claire's situation where she's now, where her child's got better, then when you come to a flare, what I say is, first off, use an anti-inflammatory like ibuprofen for a short period of time. And I say 5 days to start with, regularly, 3 times a day for 5 days. Because if it's something as simple as an influenza, not influenza, but, you know, rhinovirus or some other immune stimulation, and actually that immune stimulation might be something as simple as a loose tooth or knocking their foot, or, you know, we've learned this over time, haven't we? We've seen this.
Absolutely.
Subtle things that just trigger the immune system and just raise the baseline. Then your symptoms return. And what you want to do is separate that from something where you need to give antibiotics. So start with 5 days antibiotics first. If that does the trick and they're fine at the end of that, then great. And if it doesn't, then you may need to give antibiotics. Pretty much, yeah. And in that situation, I'd give another week or maybe 2 weeks of antibiotics and then see where we are. And I think that you're absolutely right in what you say, Amy, about we make sure that we target the patient in terms of what they need. So
sometimes you need steroids.
Yeah, and there's no one shoe fits all. You can give a very large boot that you can all put your foot into, and it might work, but it's about your doctor learning about what you need and actually, customizing treatment for you.
Right.
At what point would you consider IVIG? Do you think that there's a common number of IVIG treatments to bring a child back to baseline?
A common number?
Yeah,
I see.
What she's asking.
Sure. Okay. I see.
In what percentage of cases do improvements hold as well?
Mm-hmm. Well, I find that IVIG works well for, so right now, as I said, I use it particularly with pandas, strep-based illness. So it's really pandas. I haven't used it that much for PANS unless there's a good reason. That's a lot to talk about. So I keep it for the strep kids right now, as well as kids with eating disorders, very acute OCD, where it's really, really interfering with their ability to function. And I know that they are sensitive to antibiotics, and they're sensitive to steroids, and they're sensitive to anti-inflammatories, but it's not enough. So that's a time that I use it, especially if someone is having, significant food-related issues, not eating type of a thing. I will also use it when a child is flaring so often that they are losing their baseline. Like they can't get back to where they were anymore before the flare, or they're at risk for not getting back to where they were before the flare. Or if every time I try to come down in their treatment, it doesn't stick. I mean, I will still try and be sure I've identified and treated or removed, whatever immune triggers that I can possibly think of. I'll be sure they don't have a sinus infection, clean up the gut, sometimes do a kitchen sink approach, be sure they're not in mold. I'll do my best, but if I've done those things and that child cannot maintain stability, and they're sensitive to anti-inflammatories, I'll use IVIG and get them off the roller coaster. The majority of my patients that I've done IVIG on are really 1 or 2 and done, maybe 3 and done. It's true. And there's definitely exceptions to that. Kids with immune deficiency, they seem to do better with a few more IVIGs, just to help them, I think, extinguish the infections that they're not able to get rid of on their own. And, we can throw antibiotics and antivirals at someone, forever, but their own immune system ultimately needs to be able to mount a response and get rid of that stuff. So that's what the IG actually does for kids that have an immune deficiency. It brings those immunoglobulin soldiers in that they're unable to produce on their own, but I produce in abundance, so I can clear out infections on my own. So for those kids, sometimes I will do them more often, or I will do some low dose. Like I'll switch over to sub-Q for a while once we've achieved neuropsychiatric stability, but their immune function is just so poor. Some of those kids will do sub-Q IV for a while, and just see if we can bump up, their innate immune response. And sometimes on older kids that have been sick for a long time but misdiagnosed or just on the roller coaster of treatment that never stuck, and I see them much later, sometimes I will do once a month if we can get it covered, or if parents, can afford it, once a month infusions for maybe 3 or 6 months, just to really try to get them all the way back onto a level playing field. If they're 18, 19, I see a lot of young adults, in their early and mid 20s. So those kids may end up needing more. But overall, I do 1 or 2 or 3 and done. Mostly 1 or 2 and done.
And I think here in the UK, the group that are immune deficient, confirmed,
right,
there's not a problem there. They will get IVIG, but it's those where they appear to be on their pathology to be completely immunocompetent. So my take on this is that we in the UK, we've learned to live without IVIG, and a lot of the patients I've seen that have had IVIG tend to have a response that's relatively short-lived. Yeah, so but what they do get is this dramatic improvement, which is very quick. But then it then dies down. Now, there we could employ techniques like you've developed in the US, where you give recurrent treatments, or you give them treatments over a long period of time. But we haven't got that ability over here, unfortunately. So it's not something that we can tap into. So
like somebody who I give IVIG to, I'm going to have them on antibiotics or antimicrobials of whatever type we need to keep them covered. And I'm also going to, I don't usually do IVIG on someone that, I haven't done a stool test on. I don't know what's going on. Some kids have a lot of gram-negative infections, in their intestines. They have inflammatory changes, so actually, that's part of my integrative toolkit. I do stool testing on everybody before IVIG, because it could be a big hidden trigger, and also, can produce lipopolysaccharide all by itself, like separate from PANS and PANDAS. Having certain kinds of bacteria in the intestine that are overgrown can cause systemic inflammatory changes. Right? LPS. So.
Okay, let's move on to got a question on coronavirus and Kawasaki-ish symptoms and their prevalence in children. Do you think there's going to be a silver lining here for perception of sudden onset inflammatory response to immune triggers, and how that might shine a light on PANS PANDAS?
You're asking me?
That's a great question.
I hope it does. I mean, all of a sudden we're getting all this telemedicine. People are getting reimbursed for telemedicine. That's nice. There may be more services and more awareness, more sympathy. But the whole notion of viral illness causing these neuropsychiatric, and intense neurological impacts could make people more sympathetic. I would hope so. What do you think?
I think this is a really interesting question, and I think there's a lot more to this that it probably needs a couple of hours of conversation over a beer, actually. So here's what I think. I think that I sound like Jeremy Clarkson, don't I? I think that the recent outbreak in coronavirus there's a couple of symptoms that are really very, very interesting, and in particular the loss of taste and loss of smell. Yeah. And one thing that we've seen recurrently in some of these patients and these are elderly patients generally that do die, is that they seem to function with very low oxygen levels, like their oxygens are 30–40% functioning. And in fact, we had somebody who wrote out her will, completely conscious, low saturations, but was able to write out her will before she died.
What was her saturations?
Between 30 and 40%. Okay. Now, we're seeing this again and again. People, they seem to forget how to breathe, and it seems to be something happening in the brain.
Wow.
And that's really, and then so when you then transplant that onto group A strep and all the Th17 work and how you get transmission of infection up the into the olfactory lobe and attacking the brain in that direction. Yeah, you know what? Maybe there's something in this. I mean, it's very early days for coronavirus, but yeah, it's an interesting area.
It is a very interesting area for sure.
But remember that in terms of what we're seeing so far and there was another question about PANS and coronavirus, that it doesn't appear to be a problem for PANS PANDAS for children specifically. I don't know what your experience has been in the US, but it doesn't seem to be a trigger for the kids that I've seen over here.
I've had 2 kids that are positive for coronavirus. Well, one I'm waiting to see if she has coronavirus or not. But interestingly, both of them have had a fever for over a month, low-grade fever. That just kind of comes up and, hovers for over a month.
Yeah.
The one older girl, her PCR was negative, but, we pushed for the antibody testing and it was positive. So there's that. And then this other mom, it's hard to get her to want to test. She has a little girl, and I just haven't been able to get her tested yet. But I'm highly suspicious. She also has just some mild flare behavior, overall not doing poorly. But this fever, this unrelenting fever, is really interesting. I mean, over a month. Are you seeing that?
So there have been a couple of patients with prolonged fever. We've got this condition, which is I don't know whether you're adopting this title in the US, which is this multi-system inflammatory condition in children that's associated with coronavirus, yeah? So
yeah.
I think that was first described over here, which was people just seeing these children reacting abnormally. And actually, interestingly, the diagnostic profile for that condition, you don't have to test positive for coronavirus, right? So that's and there's so you do not have to have that syndrome. And the reason for that is because what we've said is the gold standard is the RT-PCR, the PCR swab that we send off that looks for genetic material. So that's our gold standard, okay? But if you don't do the swab properly, your chances of actually picking up the test on PCR is only 30%. So if you're basing everything on your PCR test, then you're on pretty shaky ground there, and it doesn't.
I agree. I mean, unless it's like a huge sputum sample, or you've got something that's likely heavily infected, but routine PCR.
So if you do a bronchoalveolar lavage, the pickup rate's about high 80s, early 90%. Right. If you go to sputum alone, it's about 70%. And nasal swabs about 50%, and then it goes down to about 30%. So it's not we've not really got there in terms of testing and accurately testing. So there is a big hole there in terms of what we're seeing. So I think, yes, if you have a child who's got this prolonged temperature, yes, you need to look for other things as well. But it could be coronavirus. In an immunocompetent child, though, they should be getting better by then. It's usually quite a short illness in the majority of children. Okay. 5 days of ibuprofen rescue has always worked very well for us. When in the US, they did use naproxen, and it gave same benefit. That's a long release formulation. But interestingly, it wasn't as effective as ibuprofen in severe flares because they were only able to give it twice a day. And then she also said that other than antibiotics, we've had a significant benefit from 2 separate steroid bursts, 1 week days tapering bursts that brought the child back. Fluconazole was also massively important to control yeast. Their child is PANS, not PANDAS, and they've managed to switch fluconazole for allicin max. because of after monitoring liver inflammation. So that was with azithromycin plus fluconazole long term. That's quite interesting. Is that something that you've come across as well?
Me needing to use antifungals?
Yeah.
I use a lot of antifungals. I don't use diflucan or fluconazole with Zithromax, right? I'm not sure that's a good combination. But I use them separately, and I use nystatin. You know, also sometimes kids that have been on or going to be on antibiotics for quite a while, it's very easy to tolerate. It's really good for specifically just any candida overgrowth in the intestine itself. So easy to tolerate. Yeah.
Yeah. Interesting. Shona's come back with a comment that when we were talking about the oxygen levels, and she said that that this is what happened to her child when she went to the GPs with strep in the throat and a collapsed lung. She said at the GP office she called an ambulance. Oxygen sats were so low, yet her daughter was chatting, eating a sandwich. That's amazing, isn't it? Amazing.
It's incredible.
Okay, we've got 10 minutes left, so I'm going to rattle through as many questions as we can. Mind what is considered normal in the UK, up to 200, and the fact that the tests may be based from strep from the 80s, 90s. Would Amy consider an ASO of 200 to be significant?
An ASO of 200? It depends a little bit on the age. The question to that is, it depends. It depends on the child, the story. Have they had ASOs before? What's their age group? It kind of, that's what I have to say. It depends. If they're older, I'm more likely to give more credence to it. Sometimes little kids, I think some of the ASO ranges, depending on the lab, can go up to 375, you know, because they're around strep all the time. So I don't know. It's too vague. I'd be more interested in the story.
Yeah. Okay. I mean, I think from my perspective, if the way that I often describe it to the parents is it's about the sticky, because I believe in the receptor antibody mediated mechanism. So it depends on how sticky your antibodies are. So low antibody levels can still have a dramatic effect. So in some ways, the numbers are not particularly relevant. It's about what they do. But in an environment where we have to get evidence for what we do, they're very useful for the treating physician to ensure that he has the evidence to treat his patients. I think that's something.
I would have said that very thing. But it's great how you just said that. Yeah.
Okay. Anonymous has said, why is PANS PANDAS still controversial in the UK, and how is it viewed in the US? It's kind of done
It's controversial. It's controversial, except there have been some really interesting gains. You know, this year, I think there's been some literature. Dr. Melamed just came out with his IVIG study, right, of 21 kids who, you know, demonstrated significant benefit in all 21 kids. So that's a really good study. There's the information from Columbia about how the blood-brain barrier is actually breached. There's a wonderful video on that on YouTube or on pandasnetwork.org if you want to take a look at that. And there are even a couple of other articles about specific antibodies in the striatum of the basal ganglia, the cholinergic interneuron antibodies, right? That study coming out from Kyle Williams at University of Minnesota, not Minnesota, UMass, Harvard, is really interesting. And so there's more and more information coming out. And, you know, to me, the question is that information just going to speak to people like us who already have experience and we're believers of pandas? Or are they going to help educate others.
Yeah.
So depending who you talk to, you're just going to get a different answer.
Okay, next question. So this is from she wrote in for this one. So she's got a son who's nearly 14 years of age, had symptoms at onset at 10 years of age with tics, OCD, and this was after a sore throat. The symptoms increased to the point of which he had 100 motor tics a day, vocal tics, and constant OCD behaviors, which were changing. Diagnosed with PANDAS in September 2017 with an AST of 400. Had 5 months of coamoxiclav with a probiotic, 2 further 6-week courses to manage flares, ASOT to reduce to 200 after the course of antibiotics. Symptoms hugely improved. Agreed no further antibiotics as such good recovery, but referred to CBT to manage residual symptoms and habitual behaviours. So he's been referred for CBT, and psychologists are aware of PANS PANDAS.
That's good.
And she says her son is left with mild tics and OCD, which flare with stress and excitement, but he's improved massively since those initial dark days. Enjoys a good quality of life, but is affected at times by what happened to him. And her question, based on that history, is there evidence and an expectation that children should return to baseline following the recommended and appropriate treatment? Over to you, Amy.
That's a big, fat question. That is a very, very big question. I really try very hard to get kids to baseline. I just do. I encourage parents to not, until we really, really know what's going to happen with any child, I usually encourage them to not tolerate a baseline drift, and keep working on it as long as your treatments are working. I mean, if for that boy, he doesn't respond to therapy anymore, he doesn't respond to antibiotics, he doesn't respond to anti-inflammatories, for example, then it could be that maybe you've done about as much as you can. I mean, I'm always looking for other things like mold that can keep things going, just for good measure. But sometimes kids are sick long enough during brain development, and normal development is usurped. It's taken over by these other brain loops that are established during these inflammatory times. And so it can change the path of development of their brain. And so cognitive behavioral therapy, for example, and other ways of, I kind of think of it as rewiring those brain loops, or unwiring or restoring, what was taken over by these brain loops, as a big part of healing and getting them to their baseline.
Yeah.
Even when the inflammation is gone, they may still need to do that kind of work to untangle the pathways.
Yeah, it's those ingrained behaviors that we come across. That's where psychiatric support and psychological support is really important. There is, I mean, the positive is that as we've raised awareness of PANS PANDAS, and PANDAS in particular, we're getting more parents coming with their children a lot quicker. And when they do come, if you get in early with treatment, I think the outcome's a lot better. And actually, I would say there are quite a large group who, if treated quickly, will get back to baseline, but you should expect those flares in the future with immune stimulation or another strep infection, which is the normal immune response. So so basically get in there as early as you can. Just said his son's ASO was 1300 1 year ago, and after a year on antibiotics, he's still at 1050. And he's saying IVIG is our next step. What do you think?
Obviously, I would always need to know more before making a recommendation, but I would consider tonsils in a child like that. I'd be sure and check for any family member that may actually have strep. Sometimes there's reservoir in the house. I see that a lot with persistently high strep titers, that they're just bouncing off of someone in the home who may not be symptomatic, and the tonsils.
Yeah, tonsils is a big one, isn't it? I mean, from my perspective, Ben, I think there's still a streptococcal drive somewhere that you've not quite got to. So for those numbers to be so high, even with antibiotics, it's almost like you're fighting a battle and you're holding the dam at bay, but you're still getting some water spilling over the top. So really good search. I agree with Amy. Explore looking at tonsillectomy if that's not happened already. Look at the gut in particular. Look at the gut in a big way, because that's usually a problem. Make sure you exclude celiac disease, and also look at the perianal area to make sure there's no inflammation on the skin around there. Yeah, Amy?
Mm-hmm. I was also thinking that if he's been on the same antibiotic all year, you may want to try something different, because I know a lot of people who don't think about stuff like intracellular carriage or biofilm with strep, but there can be. So maybe if he's been on Augmentin, maybe do a trial of clarithromycin or Zithamax, or if he's on Zithamax, do a trial of Augmentin or amoxicillin or Keflex, and just see if you can come at it differently.
Okay, that's great. Thank you, Amy. Okay. So you mentioned the big pandas moment for your son, being sensory sensitive beforehand. We always thought my daughter was a highly sensitive personality type rather than anything else, but could pandas have been lurking a long time before the big infection stroke symptoms?
Yeah, I think that it is. I think that if you really look through your child's history, you can see little blips that are associated with whether it's known infection or not infection, but those same kinds of behaviors or losses that they then seem to recover from. Like I remember when my son lost his handwriting and some other sensory issues, and we ended up doing occupational therapy. To this day, he doesn't let me live it down. I put him in handwriting camp, over the summer. But he had remarkable recovery. So they said, oh, we've never seen anybody recover their handwriting like this. So this quickly, this dramatically, they've never seen it. And so I just think, well, maybe he got over the illness because he had, been sick a few times that year, and I looked through his early stuff. He had some pretty good handwriting, and it was gone. He had like a true severe dysgraphia. And just a little bit of therapy put him right back in. Well, maybe he was going to get better anyway, and then that extra brain loop support, really pulled him out of whatever might have been stuck. So, and then he just went on and was great until the next time. So it's always retrospective.
Okay, that's brilliant. Amy, thank you. It would be really nice to get some feedback from everybody. So if you've got any thoughts about how it went tonight and whether you'd like us to do this sort of thing again, please leave us a message, put some messages on Facebook, let us know so that we know whether or not this is worthwhile for you or if it's a complete waste of your time and not our time.
I'm really sorry if it is. I'm so sorry.
Thank you so much for coming over and for your time.
It was really, thank you very, very much for having me. And it's really fun to talk to you.